You walk into a small pharmacy on a corner you've passed 100 times. Someone behind the counter knows your name, asks about your kid's ear infection, and hands you a bag of pills. It feels like the simplest business in the world. Buy medicine wholesale, sell it retail, pocket the difference. A doctor writes a piece of paper, you fill it, you get paid. It's the same logic as a hardware store or a coffee shop, just with a health license on the wall. That picture is almost completely wrong. Most independent pharmacies in the United States aren't setting their own prices, aren't choosing their own margins, and in a meaningful share of prescriptions, aren't even guaranteed to make money on the sale that just happened in front of you. The pharmacist behind that counter can fill your prescription, watch you walk out the door, and only find out weeks later, sometimes months later, whether that transaction actually lost the business money. To understand how that's possible, you have to understand who is really running the pharmacy business, and it isn't the pharmacist. The version everyone assumes.
Here's the version most people carry around in their head. A pharmacy buys drugs from a wholesaler or manufacturer. It marks the price up. Your insurance pays part of it, you pay a copay, and the difference between what the pharmacy paid and what it collected is profit. Simple retail arithmetic. If you own the store, work hard, keep good relationships with your regulars, and manage your inventory, you should do fine, the same way any small business owner does fine, by controlling costs and serving customers well.
That model does exist, technically. It's just increasingly not the model that determines whether a pharmacy survives. The real determinant sits one layer back, in a part of the healthcare system that almost never appears in the transaction you see. It's called a pharmacy benefit manager, or PBM, and if you've never heard of one, that's not an accident. It's basically the point. The middleman nobody sees. A PBM is a company that manages the prescription drug benefit for insurance plans, employers, and government programs. When your employer sets up your health insurance, they typically don't negotiate drug prices themselves. They hire a PBM to do it. The PBM decides which drugs are covered, negotiates rebates with drug manufacturers, builds the network of pharmacies you're allowed to use, and, this is the part that matters most for a pharmacy owner, decides exactly how much each pharmacy gets paid for every single prescription it fills. 3 companies dominate this business: CVS Caremark, Express Scripts, and Optum Rx. Together, they process the large majority of prescription claims in the country. Each of them is attached to a much larger corporate structure. CVS Caremark sits inside CVS Health, which also owns Aetna and thousands of CVS retail pharmacies. Express Scripts is part of Cigna. Optum Rx is part of United Health Group, which also owns United Healthcare. That detail is going to matter a lot later, because it means the same corporation can be the one deciding how much your local independent pharmacy gets paid, while also owning a competing pharmacy chain. So the first correction to the popular picture: a pharmacy doesn't really set a price and sell a product. A pharmacy fills a prescription and then waits to be told what it will be reimbursed. That's a fundamentally different business than the coffee shop model. It looks like retail. Economically, it functions more like a contractor who has already agreed to accept whatever the client decides to pay after the work is done. Selling below cost. This is where the healthy-looking transaction starts to hide something. When a pharmacy fills a generic prescription, the PBM reimbursement is usually based on a benchmark price for that drug, adjusted by a formula, plus a small dispensing fee. In a well-functioning system, that reimbursement sits comfortably above what the pharmacy paid to acquire the drug. In practice, it often doesn't. Generic drug prices can swing sharply and unpredictably. A shortage, a manufacturing problem, a single supplier exiting the market, and the acquisition cost for a common generic can jump within weeks. PBM reimbursement schedules don't always update at the same speed. When they lag, a pharmacy can end up paying more to acquire a drug from the wholesaler than the PBM is willing to pay them back. The pharmacist fills the prescription anyway, because refusing to fill it means turning away a patient who needs medication and damaging the relationship that keeps the business alive. The prescription gets filled at a loss, and the pharmacy owner often doesn't have a real-time way of knowing that in the moment. Independent pharmacy trade groups, including the National Community Pharmacists Association, have flagged below-cost reimbursement on generics as a recurring industry-wide complaint for years, not an isolated glitch. That alone would be a serious structural problem, but it isn't even the most counterintuitive part of the system. Getting billed after the sale is already closed. Imagine you sell something, The transaction closes, the money settles into your account, and then months later, the buyer reaches back into your account and takes some of it back. For reasons connected to performance metrics you had limited ability to control at the time of the sale. That sounds like it shouldn't be legal in most industries. In pharmacy, for years it was standard practice through something called a DIR fee, direct and indirect remuneration.
DIR fees started as a mechanism tied to Medicare Part D plans, meant to account for rebates and price concessions that get sorted out after a plan year closes. In practice, PBMs use DIR fees to claw back money from pharmacies retroactively, often tied to performance scores, things like whether patients adhere to their medication schedules that an individual pharmacy has only partial influence over. A pharmacy could dispense a drug, get paid an amount that looked survivable, close its books for the month believing it had made a small margin, and then receive a retroactive fee months later that erased that margin or turned it negative. The pharmacy had no reliable way to price for that risk in advance because the size and timing of the clawback wasn't fully knowable at the point of sale. This became such a widely documented problem that the Centers for Medicare and Medicaid Services eventually intervened. Starting with Plan Year 2024, CMS restructured how DIR fees work in Medicare Part D specifically, moving more of that cost to the point of sale instead of allowing retroactive clawbacks. It's a meaningful reform, but it also confirms how significant the problem was. A federal regulator concluded that pharmacies were carrying financial uncertainty that shouldn't have existed after a transaction was already complete. Now put these two pieces together, because this is where the real system starts to reveal itself. The chain reaction.
Start with reimbursement rates that can fall below acquisition cost on generics, which make up the overwhelming majority of all prescriptions filled in the U.S. Generics account for roughly 9 out of every 10 prescriptions dispensed, while representing a small fraction of total drug spending, because they're cheap per unit. That single fact tells you something important. A pharmacy's business is built on high volume of low margin, sometimes negative margin transactions. Brand name drugs carry better margins, but they're a much smaller share of the prescriptions walking through the door.
Thin or negative margins on the bulk of your transactions mean a pharmacy survives on volume and on the front of store business. The greeting cards, the vitamins, the snacks, the photo printing, plus a handful of higher margin services like vaccinations and medication therapy management. That's the second correction to the popular picture. The product being sold, the pill itself, is often not where the value comes from. The dispensing fee, the front store sales, and ancillary clinical services are quietly propping up a core prescription business that may not be profitable on its own.
Now add retroactive DIR-style clawbacks on top of that thin margin, and you get a business that can look financially stable on paper for months and then discover it wasn't. When margins compress this much, independent pharmacies lose the ability to absorb a bad month, a slow season, or a rent increase. They also lose negotiating leverage because an individual pharmacy owner negotiating against Express Scripts or CVS Caremark is not a negotiation between equals. It's closer to being handed a contract and told to sign it or lose access to the insurance networks that most of your patients are on.
The behavioral response to that pressure is predictable. Independent pharmacies either sell to a chain, join a larger buying group to get slightly better terms, cut staff and hours, or simply close. The National Community Pharmacists Association and various state pharmacy associations have tracked a steady, ongoing wave of independent pharmacy closures over the past decade, concentrated disproportionately in rural areas and lower-income neighborhoods. The places where a pharmacy closing doesn't just mean one fewer business, it can mean the nearest pharmacy is now many miles away. Researchers and public health officials have a term for the result: a pharmacy desert, a community where residents have to travel a significant, sometimes prohibitive, distance to fill a prescription. Rural and underserved urban communities show up disproportionately in these studies, which lines up with exactly the population that thin PBM margins hit hardest, because those are also the pharmacies least able to make up the shortfall through front store retail or an affluent, high-volume brand name customer base.
That's the domino effect. It doesn't start with a dramatic single event. It starts with a reimbursement formula quietly not keeping pace with generic drug price swings, compounds through a retroactive fee structure, and ends with a measurable change in whether an entire community has a place to fill a prescription.
The case that made this visible:
For a long time, this system operated largely out of public view because the contracts between PBMs and pharmacies typically contain confidentiality clauses that keep the actual reimbursement numbers secret, even from the state and federal programs paying for the drugs. In 2018, that secrecy cracked open in Ohio.
Ohio's Medicaid program pays for prescriptions for low-income residents, and like most states, it had outsourced the pharmacy benefit management side of that program to PBMs, including CVS Caremark and OptumRx. The state commissioned an independent audit to understand exactly how much of its Medicaid drug spending was actually reaching pharmacies versus being retained by the PBMs managing the program. The audit uncovered a practice known as spread pricing. The PBM would charge the state Medicaid program one amount for a prescription, reimburse the pharmacy a lower amount for filling it, and keep the difference, the spread, as its own revenue, without that markup being disclosed to the state.
The Ohio audit found that in a single year, PBMs had kept roughly $224 million through this spread pricing mechanism, a figure state officials themselves described as far higher than expected. To put that in perspective, that's money that was designated as taxpayer-funded Medicaid drug spending, intended to move from the state to the pharmacies actually providing care, that instead stopped at an intermediary most patients and even most state officials didn't fully understand existed in the middle of that transaction.
The fallout was fast. Ohio terminated its spread pricing contracts and moved to a transparent flat-fee pricing model for its Medicaid pharmacy program. Other states began auditing their own PBM contracts. Congress and the Federal Trade Commission both opened broader inquiries into PBM practices in the years that followed. And the FTC has since published interim reports examining PBM market concentration, vertical integration, and the effect of PBM practices on independent pharmacy viability. None of that undoes what already happened to the pharmacies that closed or nearly closed during the years the spread was hidden. But the Ohio case did something important for the public record. It turned an abstract complaint from pharmacists into a documented, audited number that regulators couldn't easily dismiss.
That's the value of this case study for understanding the whole industry. It's not that Ohio was uniquely exploited. It's that Ohio happened to be the state that looked closely enough, and what it found matched what independent pharmacists across the country had been describing for years without the receipts to prove it. How the industry adapted. Faced with this squeeze, the system responded in a few distinct directions, and they pull against each other.
The largest players leaned into vertical integration. If the money and leverage in the system sit with the PBM, then owning the PBM, the insurer, and a pharmacy chain all under one corporate roof means the squeeze on independent pharmacies becomes a competitive advantage rather than a threat. CVS Health and United Health Group both fit this structure, where the same organization can influence reimbursement rates while also operating pharmacies that receive them. That's the counterintuitive insight worth sitting with for a second. A business model that looks anti-competitive on its face, one company effectively setting the price it pays itself, has become a normal, disclosed feature of how large chunks of the U.S. drug supply chain now operate.
Independent pharmacies, without that scale, adapted differently. Many joined group purchasing organizations or pharmacy services administrative organizations, pooling their buying power to negotiate PBM contracts collectively instead of individually, similar in spirit to a union negotiating on behalf of many small employers at once. Others diversified revenue away from prescription dispensing entirely, leaning harder into vaccinations, point-of-care testing, medication therapy management, and compounding, services with reimbursement structures less dependent on the generic drug spread. And a wave of state legislatures, following Ohio's lead, passed PBM transparency and regulation laws requiring disclosure of spread pricing, restricting retroactive DIR-style fees, or setting minimum reimbursement floors.
None of these adaptations fully solved the underlying structural imbalance. They mitigated it unevenly, state by state and pharmacy by pharmacy. The optimistic outcome versus the realistic one. In the best-case version of pharmacy ownership today, an independent pharmacist operates in a state with strong PBM transparency laws, joins a buying group with real negotiating leverage,
builds a loyal patient base that also uses the store's higher-margin clinical services and treats prescription dispensing as one part of a diversified small business rather than the whole business. That pharmacy can be genuinely profitable, valuable to its community, and resilient.
The realistic negative outcome, which shows up repeatedly in the closure data, looks different. A pharmacist buys or inherits a store in a lower income or rural area where patient volume is lower and the population is more dependent on Medicaid and generic drugs, exactly the segment most exposed to below-cost reimbursement. Margins stay thin for years. A retroactive fee or an unfavorable contract renewal arrives at the wrong moment. The owner can't absorb it, can't get better terms because they lack negotiating leverage against a PBM with a national network, and eventually sells to a chain or closes outright. The immediate financial failure is the owner's. The longer-term cost is the community's, in the form of a pharmacy desert that can affect medication adherence and health outcomes for everyone who used to walk to that corner store.
Both outcomes are currently real, and both are happening simultaneously across the country. Which one an individual pharmacy lands in depends less on how well the pharmacist runs the business day to day, and more on structural factors, mostly outside their control. Which PBMs dominate their state? What percentage of their patient base is on Medicaid or Medicare Part D? Whether their state has passed reimbursement protections, and whether they have the scale to negotiate instead of simply accept.
What this is really about. Go back to the opening image, the friendly corner pharmacy, buying low and selling high like any small business. That picture isn't false so much as incomplete in the one place that matters most. A pharmacy looks like a retail business selling a product. Underneath, it functions as a service business operating inside a pricing system it doesn't control, run by a small number of companies that sit on every side of the transaction, negotiating the price, setting the reimbursement, and, in the largest cases, owning competing pharmacies at the same time.
The pills are the visible part. The real economics live one layer back, in contracts most patients never read, formulas that update on someone else's schedule, and fees that can arrive months after the sale is already closed. Understanding that doesn't just explain why your neighborhood pharmacy might disappear. It explains why, in this system, filling a prescription and making money on it stopped being the same thing.